Hello, everyone. Keep joining. We are giving some time so that more people can join. After that, we will start. Hello, everyone. Let's just start. So, who is with me? Anyone can share their screen. Anyone has our question bank? Because I cannot reset my question bank. I've talked to my. Oh, I have resetted my question bank successfully. Okay. So, who is with me? Who wants to read the first question? Hello. Who wants to read the first question? Uh, Dr.
Assalamualaikum.
Mimi?
Yes.
Yeah, Dr. Mimi, start.
A 24-year-old boy got hit on right side of the head with a baseball bat. He is suspected to have developed
Hmm.
developed a extradural hematoma. The vessel
Yes.
responsible for it enters cranium via
Okay.
uh, foramen
Read the options.
spinosum, foramen lacerum,
Hmm.
foramen rotundum, foramen
Yeah.
ovale, foramen magnum,
Okay, what's your answer?
foramen spinosum.
Great. Now, you tell me that what's the vessel responsible?
Middle meningeal artery.
Great. And it's a branch of?
Branch of
Maxillary artery.
maxillary.
Yeah. Yeah, great. Maxillary
Hmm.
artery. So,
Maxillary artery branch of external carotid artery. Okay.
yeah, great. So, this is a very important question, and you will have questions from these points, like the points I said. Okay. Branch of maxillary artery and middle meningeal artery and foramen spinosum. Very important. So you remember these 3 points always. Okay, moving on to our next question. Okay, next question. Who wants to read it? Anyone? Dr. Mimi, read it again.
A 45-year-old woman complains of
Yes.
vertical diplopia when reading
Yes.
or going downstairs. On exam, her left eye can depress when adducted.
Yeah.
Tilting her head to the right improves symptoms. Where is the lesion?
Okay, read the options.
Left oculomotor nerve, right abducens nerve, left trochlear nerve, right optic nerve, vestibulocochlear nerve.
This is a very easy question. What's your answer?
Hmm.
Like, you know what's the nerve? It's just right or left. That's problem, right?
Yeah.
Okay, think a little bit.
Maybe C.
Okay,
Trochlear.
let's just who reads the question? She answers. Okay. Next question you read and you answer. Okay.
Yeah.
Okay, no problem. Answer. Think a
Left
little bit
trochlear nerve.
then.
And
Okay, exactly.
left
Left
trochlear nerve.
trochlear nerve.
Yeah.
Because your see,
Mm.
we have what did I tell you during class that what's a vertical diplopia? Like you see two objects, one above another. Okay. And then I cannot depress. So if this is the eye, can you hear me properly?
Yeah.
Okay, okay. Let me just draw the eye and show you. So this is the eye, this is the eye. Okay. So what happens when eye is adducted, or so this is the eye, this is the eye. So when the eye is here adducted, it cannot go downwards. Okay. It cannot go downward. So if this is our left and this is our right. Okay. So left eye cannot go downwards. Okay. So what did I tell you? That SOD. Okay. Superior oblique downwards. Downwards and outwards. It will pull the eye downwards and outwards. So what happens when your right eye is okay? Right eye is making the image here. Okay. Right eye is making the picture of the person here. But when, so we are looking at the object here, right? This object. So right eye making the object here, but left eye, it cannot go this way. So it makes the object here. Do you understand?
Yeah.
Exactly. So what happens? I'm looking at an object. Hmm. I'm looking at on an object, and as my superior oblique is paralyzed, superior oblique is paralyzed, so I cannot go downwards. I cannot go downwards. It drifts upwards. It will go upward. So it will make an image upwards. That's why one above another, we see two objects, and that's why vertical diplopia happens. Okay, vertical diplopia happens. And D is the fourth. D is the fourth word. A, B, C, D. So 4, SO4, trochlear nerve, trochlear nerve. As left eye has the problem, so left trochlear nerve is, we have the lesion in left trochlear nerve. Is it clear?
Yeah.
Great. Anyone does everyone understand? Just say okay. If you have a question, you can ask anyone. If you didn't understand, tell me again. Okay, I'm assuming then everyone has understood it. Okay, just moving on to next question. So Okay, I think it's the same question. So moving on to okay, okay, okay. Read this question. Anyone? Anyone? Dr. Neetu? Why is there two Dr. Neetus? I don't know. One is muted and one is not muted. Anyone else wants to read the question?
Bhaiya, I would like to read the question.
Great. So this is a very easy question. Read it. So
A,
you will be reading next two questions because you got lucky. Okay.
okay, a 62-year-old woman presents with sudden onset visual loss. On examination, she has complete loss of vision in the right visual field of both eyes. Which structure is most likely involved?
Great. Read the options.
Right optic nerve. No, no, no. Sorry. Yeah,
Okay,
right
you read the
side.
options, then you answer.
Okay. Right optic nerve, left optic tract, right optic tract, left optic radiation, left temporal lobe.
Okay. So what's your answer?
Right optic tract,
Okay. Let's. What did you say?
right optic tract, CC.
Okay. So it's just your maybe you missed it. Okay, maybe you missed it. Let me just show you. So now read it again.
A
So what's your
62
point? What's your point of choosing right optic tract?
right visual field of both eyes.
Lost. Yes, right visual field of
ভাই
both
লেফট অপটিক
eyes.
ট্র্যাক্ট মানে রাইট সাইডে দেন হচ্ছে ভিশনটা রেটিনার আলমাইতে পারতেছ না তো ওই সাইড লেফট সাইডের কারণে রাইট সাইড ভিজুয়াল লস হয়েছে হ্যাঁ ধরতে পারিনি
Yeah, exactly, exactly. These questions
Contra
can be tricky.
contralateral side.
Yes, this question can
Hmm.
be tricky. I have a short video about it. You watch that again because this can be tricky. So that person has lost. So let's say this is our right eye, this is our left eye, and this is the right visual field of right eye, and this is right visual field of left eye. This is left visual field of right eye and left visual field of left eye. Now, what happened? This person has a complete loss of vision in the right visual field of both eye. See, this side right and this side right. So, what do we say? This kind of visualization. So, these two look same. Same means homo, right? Okay. So, same looking anopia, homonymous, but this is not anopia, this is half anopia. So hemi anopia, right? So we call it right homonymous hemianopia. And I would say that you just watch the video. So short I'm just shortening it, that if we have right homonymous hemianopia, we will have lesion in our left optic tract, or whole of our left optic radiation, right? Whole of our left optic radiation or left optic tract. Okay.
ওকে ভাইয়া
Okay. So
So
let's move on.
option D is correct.
Yeah,
D.
left optic tract is correct. So we
Option
have
B also,
explanation here.
there is a left optic radiation, parietal lobe.
No, 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 no. So left optic radiation, it will be the whole left optic radiation. Okay. So only parietal lobe, but optic radiation spans our parietal
Occipital.
lobe, then temporal lobe, then it goes to our occipital lobe. So it's just mentioning parietal lobe. So this is
Okay.
partial. So as this is a single best questions, so what happens? So we choose the best one. This is the best one. Okay. So we have here temporal lobe. So what if temporal lobe part doesn't have a lesion? Okay. So it will not be a complete loss of vision. It will be partial, maybe some sparing, maybe some inferior. If parietal lobe has it, then we have PITS, right?
Yeah.
Parietal
Yes.
inferior
Inferior.
and
Temporal
temporal
superior.
superior, right? So we will have inferior quadrantopia and superior quadrantopia, right?
Yeah.
So that's why this is not the best answer. The best answer would be our left optic tract.
Okay.
So moving on to our next
Thank you.
question. Okay. Okay. Read this question.
A 26-year-old man is admitted after a high velocity road traffic collision. His GCS is 3 on arrival and he is immediately intubated and ventilated. A CT scan of the
Great.
head shows a skull fracture and an extradural hematoma. He is
Yes.
transferred to the local neurosurgical unit. What is the thinnest part of the adult skull? The pterion, pterygoid, the lambda, the gamma, tegmen tympani.
Okay. So what's your answer?
The pterion.
So, well, this may not be the thinnest part, but from the options. Okay. So from the options, as we have extradural hematoma, this will be the best answer. If you think about all the bones and all the places, so this not be the thinnest part of adult skull. So this question, so the mentioned structures, from the mentioned structures, this is the thinnest. Do you understand what did I say?
Yes. Yeah.
Yes, exactly. Only from the mentioned options, this is the thinnest. Okay. And you will have questions in your exam which you have no clue of, like thinnest part, there may be other thin part too, right? But you choose from the options. And the one you have read in my classes or heard from my mouth or got questions from. So you go for the one you know, the one you have seen. Never choose an unknown option in MRCS Part A. Never. Never. The one feels familiar, the one looks familiar, choose that. And 90% cases, that will be the right answer. Okay. Remember pterion. Pterion consists of four bones. Parietal, squamous part of temporal. Remember squamous part, then frontal and greater wing of sphenoid. Remember greater wing. Okay. Okay.
Okay, bhaiya.
Okay. Should we move on to next question?
Sure.
Okay. So no. Okay. Read this question, please. Who is going to read this question?
A 66-year-old man is brought to the ED with sudden onset right-sided weakness and loss of sensation in the face and arm, but his leg is spared. He has aphasia and difficulty repeating sentences. Which artery is most likely affected?
Okay. Read the options.
Right anterior cerebral artery, left middle cerebral artery, right posterior cerebral artery, left posterior inferior cerebral artery, left anterior inferior cerebral artery.
Okay. So what's your answer?
Left middle cerebral artery.
Yes, left middle cerebral artery, but that's not the end. So you tell me why left middle cerebral artery? We have explanation here. We have explanation here, but
First
why
of
not
all,
others? Okay.
First of all, here leg is spared. So in the question, it is mentioned about face and the arm, mainly upper extremity. So for that's why I went for middle cerebral. If it was
Yes.
leg, then it would be anterior cerebral.
Great.
Then there is aphasia and difficulty repeating sentences. Most
Yes.
probably, I think is Broca's aphasia.
Yes.
So that's why I think I went for left middle cerebral artery.
Great. So you know the shortcut. So always remember in your MRCS part A, this is a surgery exam. They don't like stroke is a big part of medicine. So we don't get much question from here. So and we don't get difficult question from here too. Just remember if legs are involved or legs are more weak, it's ACA. Just determine the side. Just determine the side. Okay. So opposite side. That's it. Or contralateral side. Now, if aphasia is mentioned or hands are more weak, then middle cerebral artery. If vision is lost, then posterior cerebral artery. Simple, easy shortcut. Simple and easy. Now, there's a problem. Yes, there are bigger explanations, but don't go for that. Don't make yourself confused. There are bigger explanation and a lot of manifestation. Just forget those. To make things simple and to answer easily, you just remember that. And remember homonymous hemianopia. Homonymous hemianopia. If only homonymous hemianopia is mentioned, it's posterior cerebral artery. And if with homonymous hemianopia, you have hand weakness or aphasia or this kind of thing, it's middle cerebral
Middle
artery.
cerebral artery.
Great. So let's move on to our next question. So we have answered it. Okay. Broca's aphasia. Okay. Okay. Not important. So read this question, please.
A 28-year-old man complains of loss of taste sensation on the anterior two-third of the tongue, but
Okay.
his tongue movement and general sensation are intact. Which
Okay.
one of the following structure was most likely injured at the petrotympanic fissure?
Okay. Read the options.
Chorda tympani, glossopharyngeal nerve, lingual nerve, hypoglossal nerve, auriculotemporal nerve.
Great. What's your answer?
Chorda tympani.
Chorda tympani, most probably. Chorda tympani.
Yes. Be confident. Okay. So whatever you choose once and then never change your answer, even if it's wrong. Okay. So what happens? That's how you learn. Okay. So don't worry about it. So what's
Okay,
the
bro.
clue? What's the biggest clue here? Of course, loss of taste sensation,
Loss
but
of
with
taste
that,
sensation.
yeah, petrotympanic fissure.
Petrotympani. I got confused at that point. Petrotympanic fissure, then chorda tympani.
Yeah. See, all these things, they don't come out. They don't come out through petrotympanic fissure. They are not
Mm.
related to petrotympanic fissure. So only chorda tympani branch of facial nerve with salivatory branch, salivatory fibers, salivatory fibers. They come out through petrotympanic fissure. Petrotympanic fissure. Okay. Let me show you one thing. Let's say this is petrotympanic fissure and chorda tympani and salivatory fibers coming out. After that, whom do they meet? They meet the L, the lingual nerve. Okay. So, and they enter lingual nerve. So, lingual nerve has three fibers. Three fibers. So, lingual nerve will take touch pain temperature from anterior two-third of the tongue. Anterior two-third. And chorda tympani will take taste, and these salivatory fibers will go to submandibular ganglion. From there, we have sublingual gland and submandibular gland. Now, you can have two kind of questions. One, that your taste is gone, salivation is gone, because these are parasympathetic fibers and they increase salivation. But touch pain temperature is okay. So you tell me, where is the lesion? Where? Anyone? Just
Lingual nerve.
Chorda
where is the
tympani.
lesion?
Pe-
Like, is it
Hmm.
like
Distal.
uh, where is the lesion?
Distal.
It is proximal from, the lesion is proximal to the meeting point of lingual nerve. Do you get it now?
जी भैया.
Great. So, if this is the option that your taste is gone, taste gone, salivation gone, but touch pain temperature is okay. So, where is the lesion? So, the lesion will be proximal to the meeting point. This is the meeting point. So, this is proximal and this is distal to the meeting point. So proximal to the meeting point is the lesion. And if distal to the meeting point, the lesion, then touch pain temperature will be gone too. Okay, guys.
Okay भैया.
So okay. So let's move on to our
Sorry, Dr. Khan. Hello.
next. Hello. Yeah.
This point I have this confusion,
Yeah. Tell me.
confusion. The previous point, please. I think I asked you before about this point.
Okay. Please ask me again.
This proximal I have, if I have lingual before the meeting with the chorda tympani. This is
Yeah.
proximal, right?
Yeah. So
If
we
the
have
if
two
proximal,
kind of proximal.
Hmm.
Let's say we have a lesion in only lingual nerve. Only lingual nerve. Okay. So this is proximal to the meeting point, and the lesion is in lingual nerve. Let me tell you, touch pain temperature. Then we have taste. Then we have salivation. Now, there are two kind of proximal lesion we can have. So this is a proximal lesion and this is a proximal lesion. Let's say we mark it 1 and we mark it 2. So if we have lesion in this one position, what will we lose? We will lose touch pain temperature. And the wording in your exam will be touch pain temperature will be gone, but taste will be okay, salivation will be okay. If this is the scenario, then this lesion is also proximal to the meeting point of chorda tympani. Right?
Okay.
Now, if we have a lesion in point 2, so this will be also proximal to the meeting point. But this time we will have touch, pain, temperature okay. But taste will be gone, salivation will be gone. So both will be proximal lesion. Your answer will be according to the presentation.
So proximal, if he can say to me this proximal to chorda tympani or proximal to meeting point or proximal to lingual like this.
So
Or
yeah, They can say it, but you will have the scenario that what is lost. If all three lost, only then that's a distal lesion. If
Okay.
all three is gone, only then it's a distal lesion.
Okay.
If something spared, then it's a proximal lesion from the meeting point of lingual nerve and chorda tympani.
So if he just say meeting point without say lingual or chorda tympani, would it be lost? Just proximal to meeting point of lingual and chorda tympani. This side of M here, meeting point.
Yeah, they will say it's a just a proximal lesion. They can say that too, that it's a proximal lesion. But only in proximal lesions you have spared, like touch pain temperature, okay, taste and
Mm.
salivation gone, or touch pain temperature gone, or taste and salivation is okay. So you will have one thing okay, one thing gone. These will be proximal lesions.
Okay.
Okay, thank you. So we will be going to, okay, okay, we have seen that. We don't really. Okay, read this question, please. Anyone?
No problem. I can read.
Yeah, sure.
58-year-old man present with sudden onset weakness of his right arm and lower face. But his leg strength is preserved. He is alert and oriented. Examination confirmed contralateral facial droop, sparing the forehead and arm weakness with intact sensation. Which cortical area is most likely affected? Left precentral gyrus, right postcentral gyrus, left superior temporal gyrus, left occipital gyrus, left occipital cortex, right inferior frontal gyrus.
Okay, so what's your answer?
This is motor loss.
Yes,
So
with
it's
intact sensation.
intact sensation.
Yeah,
So either post-central gyrus. Uh, this is motor gyrus.
yeah, yeah.
And
Motor gyrus.
examination confirmed contralateral facial drooping, sparing weakness. I think um, right postcentral gyrus, but it's same side. Uh,
So do you want to think again?
I want. I want.
Okay. Okay,
Uh,
so let's just choose it. And this is a motor deficit. We have explanation here. So this is a motor deficit. So it's we don't have any sensory loss. Okay. So left
motor center.
precentral, yeah. So left precentral gyrus controls contralateral voluntary motor function. Okay. Contralateral voluntary motor function. And postcentral gyrus, our sensory cortex. And it's in the wrong side, not right. So this is not the right option. Then again, left superior temporal gyrus, it controls our auditory and language area. You can say Warnick's area. Warnick's area. Okay. And left occipital, we all know occipital deals with vision. And inferior frontal gyrus, it's just Broca's area. So this is you can say that as this is a motor deficit, it doesn't really make sense. E. Okay. So we have here motor weakness with intact sensation. So motor cortex, we will choose motor cortex. Okay. Then face and arm involved, leg spared. So it's most likely would be lateral portion of the motor homunculus. What do you say? It? Lateral portion of motor homunculus. And as its right-sided weakness, the lesion would be in left hemisphere. Okay. So left precentral gyrus would be our best answer here. So these are a little bit tough questions. They don't generally give these questions in exams, but sometimes they give. Okay. We cannot add picture set. Okay. Should we move on to next?
Okay, Bhaiya.
Okay. So let's move on to our next question. So, okay. So next question. Read this question, please.
A 41-year-old man presents to the neurosurgical department with seizures after a 1 month history of headaches.
Okay.
Subsequent investigation shows a meningioma. An
Okay.
ST1 doctor assists during the resection of the tumor, and during the dissection, the dural partitions of the brain come into view. Which one of the dural folds separate cerebrum from cerebellum? Fox cerebelli,
Okay.
tentorium cerebelli, fox
Yes.
cerebri, the
Yes.
diaphragmatic sella, pyometer.
Yes. Okay. So what's your answer?
Tentorium cerebelli.
Great. So this is our answer. That's tentorium cerebelli. We have written down all of this. Let me just tell you in short that fox cerebri will separate two cerebral hemispheres. Let me just write it. So it will separate two cerebral hemispheres. Okay. And of course, tentorium cerebelli is the answer. So you know, fox cerebri. Okay. Guys, I think I have mixed out cerebri and cerebelli. Let me write it down. So this is the cerebri one. So fox cerebri will separate to cerebral hemisphere. So this is cerebelli. So this will separate to cerebellar hemisphere. Diaphragma just covers the pituitary gland. Okay. And pyometer is not a dural fold. We all know it's just a meningeal layer. Okay. So this is an important question. Sometimes they give these questions. Okay, next question. Anyone who wants to read it? Anyone?
I will.
Yes, please.
A 62-year-old man presents with hoarseness, dysphagia, loss of gag reflex, and shoulder droop. Imaging
Okay.
reveals a skull-based tumor compressing multiple cranial nerves. Which foramen is involved? Foramen
Okay.
ovale, jugular foramen, foramen rotundum, stylomastid foramen, and foramen spinosum.
Okay. So what's your answer?
Dysphagia.
Think a little bit. We have time.
Uh, I seem to have forgotten which goes through which, but
This is very normal. We all forget which goes to which foramen. You just whatever comes in your mind, just think a little bit and then answer. Because we have time to learn. So don't worry about it.
mm,
See what are the
this
problems we are having and which nerve is involved.
where loss of gag reflex dysphagia would indicate vagus nerve, so it should be jugular foramen.
Great. I would say this is classic for jugular foramen. So we have all these things like for hoarseness, we have vagus. For dysphagia, both 9 and 10, and gag reflex 9. We all know shoulder droop, spinal accessory nerve. We all know. So all these thing this we, and remember that this has a name too. We call it Varnet syndrome. Okay, this has a name too. We call it Barnett syndrome. And other foramens, just for uh, foramen ovale. Remember, OVALE. Okay, so then foramen rotundum. What did I tell you? Pro
Max.
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 Great. Stylomastoid foramen. You all know what does go through stylomastoid foramen. Tell me.
Facial nerve.
Great.
Facial nerve.
Facial nerve. And foramen spinosum, we all know. Tell me.
Middle
Foramen
Mandibular
meningeal
nerve.
spinosum,
artery branch of
middle
maxillary
meningeal.
Mandibular
artery.
nerve.
Yes, foramen spinosum, middle meningeal artery, branch of maxillary nerve. Okay, so let's move on to our next question. Foramen questions are very important because we will have a question from foramen. So next question, who wants to read it? Anyone?
A 35-year-old woman has severe facial pain localized to the mid face and upper lip. Imaging shows a lesion compressing a cranial nerve as it passes through the sphenoid bone. Which foramen transmits this nerve? Foramen rotundum, foramen ovale, jugular foramen, foramen magnum, foramen spinosum.
Okay, so what's your answer? First
Foramen
determine
ovale,
which nerve is involved.
Foramen rotundum.
First determine which nerve is involved here.
Superior.
Trigeminal nerve. Maxillary division of trigeminal nerve.
Great.
promax,
So
foramen rotundum.
yes. So this will be your answer. So first you have to determine which nerve is involved. Okay. So then we
Okay.
decide which foramen is involved here. Okay. So remember maxillary nerve has three divisions. I mean trigeminal nerve. Where is my let me write it down. Trigeminal nerve has three divisions, right? V1 ophthalmic, V2 maxillary, and V3 mandibular. Okay. So V1 mainly will supply your forehead, your scalp, and upper eyelid. Just generalized, I'm telling, because in class I have told those more specifically. Okay. So maxillary will supply your mid face, lower eyelid, cheek, upper lip, bilabial branch. And we all know upper teeth with alveolar branch, superior alveolar nerve. Okay. So upper teeth and mandibular, of course, lower lip, chin, jaw, and of course, motor to motor to mastication, and of course, lower teeth, right? Lower teeth. And then we have lingual nerve too. We are not going there right now. So ophthalmic, maxillary, mandibular. So pain, where is the pain? So mid face and upper lip. So we have it here. So mid face is here, upper eyelid is here. So mid face and upper lip. Where is upper lip? This one. Here is upper lip. So mid face and upper lip is in our maxillary division. That is V2. Okay. So V1 goes through superior orbital fissure. Okay. V2 goes through foramen rotundum, maxillary, promax. Okay. Protundum, I call it protundum pro maxillary nerve. And V3 foramen ovale. V3 goes through foramen ovale. So you will have questions from here. Okay, so remember it. So let's move on to next question. Who wants to read this question? Anyone?
May I?
Yeah, sure.
A 26-year-old man presents to the ear after being struck in the temple with a baseball. He rapidly loses consciousness, then awakens briefly, and then deteriorates. CT scan shows a lens-shaped hemorrhage, which foramen transmits the injured vessel responsible.
Okay, read the options.
It's foramen spinosum.
Great. This is, everyone knows the answer now, and I'm happy all of you know the answer. Now you tell me what's the significance of foramen lacerum?
Foramen lacerum above it, internal carotid artery passes.
No, that's why I asked. Thing is that nothing passes with it, nothing. That's the significance. So if this is foramen lacerum, internal carotid artery is a content of carotid canal. It will go above foramen lacerum.
Yeah, I told you it's
Yeah,
not through it.
yeah, great,
Yeah,
great,
it passes straight.
great. So let's move on to our next question. Read it.
May I?
Yeah, sure.
A 45-year-old man undergoes resection of a tumor in the infratemporal fossa. Postoperatively, he has difficulty chewing and decreased sensation over the anterior two-thirds of the tongue. General only, which foramen most likely damaged during surgery?
Okay, so read the options.
Foramen spinosum, ovale, rotundum, jugular foramen, stylomastoid foramen.
So what's your answer?
May I give the answer?
Ovale,
Yes, sure.
ovale.
I think it should be stylomastoid foramen.
Yes, it should be
Um,
stylomastoid foramen.
Ovale.
yeah. Okay. Anyone? Okay. Let's go with who was reading the question?
Me, Dr. Ujma.
Yeah, Dr. Ujma. What's your answer?
Ovale.
Okay. Let us just move. Okay. So thing is that she has difficulty chewing and decreased sensation over anterior two-third of the tongue. So she doesn't have pain. Okay. So maybe you got confused with difficulty and pain. So she doesn't have pain. Difficulty in chewing, you may get confused that facial muscles may be involved. Okay, but the problem is muscles of mastication controls the chewing. So okay, so these are muscles of mastication. That's why she is having difficulty in chewing. Facial muscles, not facial muscles involved here. Okay, so that's why stylomastoid foramen will not be answered. Did you get it?
Yes.
Thank you.
Okay. Yeah, great. So the problem is maybe we all do these mistakes. We all do these mistakes and never be afraid of making mistakes, guys. That's how we learn. So difficulty chewing, and let's say if they say pain in that area, so if pain in cheek is transmitted by trigeminal nerve. Okay. Pain in that area, let's say cheek. So, and difficulty chewing due to muscles of mastication is not working properly. And plus your lingual nerve. Lingual nerve is involved. So, it's mandibular division of trigeminal nerve. Mandibular division. And it goes through, let me just repeat, V1, V2, V3. So, V3 will go to foramen ovale. Now, you tell me that V1 goes through which foramen? Anyone?
SOF.
Superior orbital fissure.
Supraorbital fissure.
Yes, superorbital fissure. V2.
Rotundum.
Rotundum.
Great. Foramen rotundum. So now you will never forget these things. Very, very good. And next question. Anyone who wants to read it?
May I?
Yeah, sure.
A 6-year-old boy presents with morning headaches, vomiting, and papilledema.
Great.
CT shows enlarged lateral ventricles, but a normal third and fourth ventricle. Which one
Okay.
of the following structure is most likely blocked?
Okay.
Interventricular foramen of Monro, cerebral aqueduct, foramina luschka,
Hmm.
foramen of Magendie,
Okay.
subarachnoid villi.
Okay. So what's your answer?
Interventricular foramen of Monro.
Okay. What's your supporting point
My
regarding
supporting
this
point
answer?
here is here the enlarged ventricle is the lateral ventricle, but the distal, that is third and fourth ventricle, it remains normal. If the answer was supposed to be cerebral aqueduct, it would have been between third and fourth ventricle. But as lateral ventricles are enlarged and it is between third and the lateral ventricle, so I think interventricular foramen of Monro will be the answer.
Great. This is awesome. This is awesome. So some people have not some people, like everyone has some question about non-communicating and communicating hydrocephalus. So we have added here a good big explanation. So I cannot explain all of it now. So it will just unnecessarily lengthen the session. So just I will tell you that from this question, you read this part. You read this part because these days they are giving communicating and non-communicating hydrocephalus sometimes. Okay. So let's move on to next question. So who wants to read it?
May I?
Yeah, sure.
A 2-month-old infant presents with progressive enlargement of the head, bulging frontally, and irritability. MRI reveals dilation of both lateral ventricles and third ventricle, while the fourth ventricle appears normal. Which of the following is the most likely site of obstruction? Foramen of Magendie, interventricular foramen of Monro, cerebral aqueduct of Sylvius, central canal, subarachnoid granulations. I think the answer will be C, cerebral aqueduct of Sylvius.
Correct answer. Lock kiya jaye. Okay. So you answered it correctly. So this is good. I think everyone will be able to answer these questions properly because you will have these questions in your exam. Okay. Just tell me, just let me tell you one thing that subarachnoid granulations. If subarachnoid granulations is obstructed, you will have all ventricles enlarged. All ventricles enlarged. Okay. So, and it will cause communicating hydrocephalus. Okay. Hydrocephalus. Okay. So just remember this thing that if subarachnoid granulations are blocked, we will have communicating hydrocephalus. Okay. So let's move on to next question. Who wants to read it?
May I?
Yeah, sure.
A 45-year-old woman presents with diplopia that began 1 week after undergoing resection of a large right acoustic neuroma, vestibular schwannoma. She reports difficulty focusing while looking to the right. On examination, her right eyeballs face abduct past the midline, while the left eye moves normally. Pupils are equal and reactive to light. Which of the following is the most likely diagnosis?
Okay. So read the options.
Right oculomotor nerve palsy, right trochlear, right abducens nerve palsy, internuclear ophthalmoplegia, myasthenia gravis.
So what's your option?
Right abducens nerve palsy.
Great. Great. So this is right. So what are your supporting points?
Here, the patient's failed to abduct past the midline. So, it's
Yes,
due
you
to
just need
lateral rectus,
one.
which is supplied by abducens nerve.
Yeah, great. So you just need one good clue and you can ignore all others. So just let me tell you one thing, that is this one. This one may be unfamiliar to you. Like if this happens, then we will have nystagmus of opposite eye. Okay. And adduction failure. Adduction failure of opposite eye. Okay. So just note this point. Okay. Just note this point. As this is unfamiliar, that's why I told you. Nothing important, never came in exam, and I don't think anytime it will come in your exam. Just remember this question, abducens nerve, and this will help. So moving on to next question. Again, another foramen who wants to read it.
May I?
Okay, okay. Tell me the names. Dr. Ujama.
Ujma.
Ujma. Okay, so you have read two questions. Let's give. What do
Okay.
I say?
Okay.
Okay. So who else wants to read?
I can read.
Yeah, sure.
A 48-year-old woman presents with progressive hearing loss, tinnitus, and
Okay.
loss of balance.
Okay.
Examination shows decreased corneal reflex and ipsilateral facial weakness.
Okay.
MRI reveals a mass in the CP angle.
Yes.
Through which foramen does the affected nerve exit the skull?
Okay.
Other
So
options
what
are
are the options?
jugular foramen A, foramen rotundum B, internal acoustic meatus C, stylomastoid foramen D, and hypoglossal canal E.
Okay. So what's your answer?
I think I should go for stylomastoid foramen.
Okay. Let's just select that. Anyone
Would
else?
it be internal acoustic meter?
acoustic meters.
Should we change the answer? Who read the question?
Um,
Due
What
to
do you think?
hearing loss,
Whatever you say,
tinnitus,
we will
loss of
answer.
balance.
Should we keep the answer or change?
I will stick to my answer.
Okay. Let's just stick to the answer. But okay. Let's just explain why. Okay. See, here we have progressive hearing loss, right? Let me just write it down so it becomes clear for everyone. Never be afraid to make mistakes. Never. This is a platform to learn. Okay. So it's just we have progressive hearing loss, tinnitus. Okay. So this goes for our vestibulocochlear nerve, right? Nerve number 8. Then we have loss of balance. And that also goes for our nerve number 8. Okay. Then we have decreased corneal reflex. So these goes for our cranial nerve 5. Okay. Because of afferent limb. Afferent limb. Okay. Then we have ipsilateral facial weakness. And that we know that this is facial nerve. That's why maybe you chose stylomastoid foramen. So this is our facial nerve 7. Okay. And we have a mass at CP angle, and this is a classic for our vestibular schwannoma. Okay, so we have 8, we have 7, we have 8, and we have cranial nerve 5. Okay,
But yeah, would you explain the afferent limb part of cranial nerve 5, please?
corneal reflex, right? Corneal reflex. We have a short video about corneal
Oh,
reflex. This
my
is a
bad.
long.
My bad.
Okay, okay. So This is a long discussion, so I will share the link and you just watch that short video. Okay. So all these, like we know that facial nerve, then we have eight, and it goes through internal acoustic meters. Okay, it goes through internal acoustic meters. Okay, guys, let's move on to our next question. Here we have an explanation. Here we have an explanation that these two are going through this, and as we have it in the angle, it can compress your trigeminal. So this one, who wants to? Again, we have that question, that kind of question, light cornea with wisp of cotton. Okay, so read it, guys. Okay, I will explain it briefly after this question. Anyone?
A 62-year-old man with headache and fever develops cavernous sinus thrombosis. Touching the right cornea with a wisp of cotton produces no blink in either eye. Touching the left cornea produces a bilateral blink. Which structure is most likely damaged? Left facial
Okay.
nerve, right facial nerve, left optic nerve, left ophthalmic nerve, right ophthalmic nerve, and right oculomotor nerve.
So what's your answer?
May
You
I
can
give the
think
answer?
a little bit. Yeah.
Thank you. I think the answer should be right ophthalmic nerve, D.
Yes, I
Okay.
concur.
Okay. That's a D. Okay. D.
Yes.
Okay. So this is the right answer. So let me just okay, this time as we have the same question, let me just explain. Let me just explain it. We need a big area. So this is your one eye. This is your another eye. Let's say, so this is your brain. Okay. So ophthalmic branch of trigeminal nerve is the afferent limb. This is our cornea. Let's say this is our right cornea. This is our left cornea. And this will, if you touch a cotton, this will take the sensation to the brain. So this is the afferent limb. And after that, brain will send signals to both eye through facial nerve. So through facial, the facial is the exit. So this is the efferent limb. Efferent limb, simple. So when you touch right eye, both eye will blink because input is okay, output will be in both eyes. Then again, if you touch the left eye, same thing will happen. So if you have a lesion in the input, let's say right side, we have a lesion or a problem. So right sided input is gone. If input is gone, right eye, no blink.
Bilateral loss will occur.
Yes. Left eye, no blink. But if you touch left eye this time, left eye input is okay. Left eye input is okay. So you will have right, left, right eye will blink, left eye will blink too. Did you get it?
Yes, thank you. Yes, thank you.
Great. But if we have, let's say we have a lesion in an exit point. Let's say, let's number it. Let's number it as 2. Let's say we have a lesion in this point 2 and this is okay. This is okay. So let's say we touch the right eye. We touch the right eye. So what will happen? Right eye will blink. But this output is gone. So left eye will not blink. Right? Again,
Unilateral
when you,
loss.
yes, again, when you touch the left eye, this time also right eye will blink, but left eye this time also will not blink. will not blink. So you tell me where is the lesion? If so, now if the question is that left eye has no blink at all, so what will be the answer? Where is the lesion?
Which eye was the cotton place?
Left eye has no blink at all, no matter where you touch the cotton. Okay, so you touch left eye doesn't blink. You touch right eye, left eye doesn't blink, but right eye always blink.
Then left side
Then there
efferent
will be
limb
in the
damage.
facial nerve, efferent limb,
Which side?
Left side.
on the
Great.
left side,
Yes.
ipsilateral.
So left side, left side, left efferent facial branch will be injured. Now, let's say we touch cotton in left eye. Okay. When we touch cotton in left eye, let me just, okay, exit. When we touch cotton in left eye, okay, both eye blink. But when we touch cotton in right eye, no eye blinks. So where is the lesion?
Right afferent.
Right afferent.
Exactly. So now the lesion is in right afferent. So this is a trigeminal nerve lesion. That means V1, ophthalmic branch of trigeminal nerve, is injured. Okay, guys. So let's move on to our next question. Mm, okay. So now you answer. Anyone read this question?
May I?
Yeah, sure.
Is 70 years old, has loss of
70.
pain, temperature, and touch over the entire right
Okay,
face.
wait. I see a different question. What's your question number?
33. Oh,
I'm saying 32. Are all of you seeing 33?
No, I'm seeing 32.
No, I'm in the 32.
Okay. So read the question from the screen.
okay.
Okay.
Mhm. A 45 years old woman has facial drop and cannot close her right eye. Light touch to either cornea trigger left eye blinking, but no blink on the right. Which nerve is impaired?
Okay. Read the options.
Right V1 5 1 nasociliary, left
Okay.
1 nasociliary, right
Okay.
facial nerve cranial 7, left facial nerve cranial 7, right abducens nerve cranial 7.
Okay. Think a little bit, then answer.
Here answer will be right facial nerve cranial 7.
Okay, let's select this one. So this is the right answer. Congratulations, you get a chocolate. Anyway. So
Um,
what's your supporting point?
my supporting point, as here mentioned, ipsilateral lesion.
Okay.
Blinking on that side.
Yeah. Okay. So here the sensory
No
input
blinking
is
in that
intact.
side. As no blinking in that side, must be right side will be the answer.
Yes, exactly. So right eye cannot blink at all. Okay. So the thing is that your right eye
And
cannot blink at all, no matter where you touch.
I have a question, sir.
Yeah, sure.
Here where the blinking side is not mandatory. I mean,
Blink.
side is not mandatory.
Yeah, side is mandatory in case of your, let's say, let me show you again a little bit. See, if right eye does not blink at all, does not, according to this question, right eye doesn't blink at all. That means when you touch your cotton into your left eye blinks and right eye doesn't blink at all. When you touch your cotton in the right eye, again input is okay. So left eye blink again, but right eye doesn't blink at all. So right sided facial is injured. Okay. Then you know that if input is not working, so at that time the side you touch, right side you touch, right side you touch, and no eye blink. No eye blink. So side is important, but it's almost always the same side.
Same side.
Yeah. So that's the beauty of corneal touch. I mean, okay. So next question. Anyone wants to read?
May I?
May I?
Yeah, sure. Okay. So
A
tell me the
70-year-old
yeah.
has loss of pain, temperature, and touch over their entire right face, including
Okay.
the buccal mucosa and anterior two-thirds of the tongue, except for the
Okay.
angle of the jaw, which remains normal. Which nerve
Okay.
supplies the spared area? Option A, auriculotemporal nerve. B, lesser occipital nerve. C, great auricular nerve. D, facial nerve. And E, glossopharyngeal nerve.
So what's your
My choice
answer?
is C, great auricular nerve.
Great. So greater auricular nerve supplies this area. So the thing we have here, loss of pain, temperature, and touch over the entire right face. Okay. So who supplies this?
This should be trigeminal nerve.
Yes. These all the sensation of your face is supplied by trigeminal nerve. We all know that. Just again. Okay. Next question. Who wants to read it?
May I?
Yeah, sure.
An elderly smoker with a lateral tongue squamous cell carcinoma reports deep ear pain. Soothes his ear with cotton. Tumor of invasion of which nerve best explains this referred otalgia?
Okay. So read the options.
Chorda tympani nerve, lingual nerve with referred pain via auriculotemporal nerve, glossopharyngeal nerve, vagus nerve, hypoglossal nerve. It's
So what's
lingual.
your answer?
I would like to disagree. I should think that it is vagus nerve by the auricular branch.
Okay.
I think it should be the
So
answer C, glossopharyngeal nerve via tympanic plexus.
so
I
okay. So
think
which
it's
one?
lingual
So
nerve.
yeah, you can present your. Let's go with Ujma. Please tell me your supporting points.
I think it's in the anterior two-third of the tongue. So its general sensation
But
is
they did not mention anterior two-third. Never assume specific things if they do not mention.
okay.
Okay. Then
Sir, can we go this with metastasis, as metastasis go? So lateral tongue squamous cell carcinoma may be
yeah.
ipsilateral to submandibular. So glossopharyngeal supplies here also, I think. So glossopharyngeal have this tympanic branch. I can go with the doctor as he said, C, glossopharyngeal nerve via tympanic plexus. Or
Okay. So let's go with this one. So here we have the lingual nerve with a referred pain via auriculotemporal nerve. Okay. So glossopharyngeal nerve can be, but lingual nerve is the best answer here. Okay, because here only lateral tongue they mentioned only. So tongue is specifically mentioned here. Okay. So tongue is specifically mentioned here. Specifically mentioned here. So that's why we will go with lingual nerve as the best option. Glossopharyngeal nerve can be if they mentioned pharynx, if they mentioned pharynx, so we can have it. So these are very close. Lingual nerve, glossopharyngeal nerve, both are very close. Okay. So as they mentioned lateral tongue, squamous cell carcinoma, and deep ear pain due to metastasis, we all know. So lingual nerve is the best answer here. I know that glossopharyngeal nerve has its supporting points too. Okay, because it has innervation to the tonsil, then pharynx, then middle ear via tympanic plexus. But we have no mention of tonsil, pharynx, or anything. So we will go with lingual nerve as the best option in this case.
how it's being referred, like lingual nerve B with auriculotemporal. How it referred then?
Well, here we have okay. So as we know that lingual nerve and auriculotemporal nerve both are the branch of our mandibular division, which is mandibular division of trigeminal nerve. So this can cause ear pain, but may not deep ear pain, but this can cause ear pain. Okay. So as it's lateral tongue lesion, we will go with lingual nerve as the best answer. But this is another right answer too. Okay, sorry guys. This is another right answer too. But in my opinion, the best answer will be lingual nerve. Okay, guys.
Okay.
Okay, let's move on to our next question.
I can read this.
Yeah, sure.
9-year-old with facial pain and vesicular rash has lesions on the tip of the nose, along with the nasal dorsum. Which nerve branch carries cutaneous sensation from this area and predicts possible corneal involvement? Infraorbital nerve, zygomaticofacial nerve, long ciliary nerve, external nasal branch of the anterior ethmoidal nerve, V1 nasociliary, nasopalatine nerve.
Okay. So what's your answer?
Tip of the nose, external nasal branch of the anterior ethmoidal nerve.
Great. So this will be our answer because tip of the nose is supplied by external branch of the anterior ethmoidal nerve. Okay. So this is like this is a classic sign. This is a classic sign. We call it Hutchinson sign. Why this? Okay, let me just make it a little bold. We call it Hutchinson's sign. Okay. So here we have tip of the nose and vesicular rash. nasal dorsum. So infraorbital nerve, we know that it supplies cheek, upper lip through labial branch. Zygomaticofacial nerve, it supplies like, let's say if I could see my face, you would see some blush. Like you see people blush, the area women used to give blushes, that exact area is supplied by zygomaticofacial nerve. And long ciliary nerve produces corneal sensation. So like long ciliary nerve, in fact long ciliary nerve supplies your pupil, sympathetic supply. Okay, sympathetic supply. And nasopalatine nerve supplies your nasal septum. Nasal septum. So just to remember these points. So it might help in one way or another. Okay, let's just move on to our next question. This is a very short question. Anyone wants to read?
A 34-year-old sustains an orbital floor fracture. He reports numbness over the lower eyelid, upper lip, and above the nose. Which nerve is
Yes.
injured?
Okay.
Buccal nerve, infraorbital nerve, mental nerve, auriculotemporal nerve, external nasal nerve. Option
So
is
what's
B,
your answer?
infraorbital nerve. Option B.
Great. So we'll go with infraorbital nerve. We all know that this area, that lower eyelid, upper lip, aloe of the nose is supplied by infraorbital nerve. So can you tell me mental nerve, which part it supplies?
Upper lower lip,
Lower lip, gene, and the
lower
mental.
lip.
Yes, lower lip. Lower lip is supplied by mental nerve. And do you remember what did I say about mental nerve? How does it
Dental nerve
become?
becomes mental.
Yes, exactly. You must remember that, you
Yes.
must remember that mandibular division of trigeminal nerve will give two nerves. One will be in front of the mandible, like inside of the mandible.
Lingual nerve.
Yeah. And one will enter the mandible. And they ask questions about it. That's inferior alveolar nerve. Inferior alveolar nerve. And it will enter the mandible. And when it enters the mandible, it will come out through mental foramen. Mental foramen. And the dental nerve will become mental nerve and supply your lower lip. They ask this question, which nerve enters the mandible? Okay, okay, this is a very short question. Let's read some big questions. You can solve it by yourself. Okay, let's read this one. Who wants to read it?
Okay, I am
May
reading.
I? Of course.
Yeah. Read it.
Following removal of a
Yeah.
submandibular duct stone, a patient has loss of taste on the anterior two-thirds of the tongue, decreased salivation from the submandibular or sublingual glands, and loss of general sensation in the same area. Which structure was injured? A.
Okay.
Lingual nerve proximal to chorda tympani. B. Lingual nerve distal to the union with chorda tympani. Inferior alveolar nerve, hypoglossal nerve, and glossopharyngeal nerve.
So what's your answer?
My answer would be lingual nerve distal to the proximal to chorda tympani.
Lingual nerve.
I
To
should
the union.
question because I asked two times.
Okay, let's just go with this. So this will
Oh,
be
sorry.
distal to chorda tympani
I'm
because
sorry,
we have
I
lost
got
all.
mixed it up.
Yeah, let me just we lost all. That will be distal. Lost two. That will be proximal. Lost one. That will be proximal. Okay, easier now.
Yes, thank you.
Okay. So let's move on to next question. Who wants to read it?
Okay, 23-year-old has otalgia and preocular tenderness from TMG inflammation.
Information.
Which nerve carries the primary sensory innervation for of the joint capsule? Facial nerve, great auricular nerve, brachiotemporal nerve, prossopharyngeal nerve, lesser occipital nerve,
Okay, so what's your answer?
brachiotemporal nerve, TMG.
Okay, so this is auriculotemporal nerve because we all know all others, they really doesn't make sense. You already know where others supply. So you can just answer it very easily. Just tell me where lesser occipital nerve supplies. Anyone?
Behind the ear.
Great, great. Always remember this thing that behind the ear and medial surface of the ear are not the same thing. Those are two different things. You get confused. That's why I just mentioned it. Okay, guys, let's move on to next question. So, anyone wants to read it?
May I?
Yeah, sure.
After parotidectomy, a patient develops gustatory sweating over the parotid region while eating. Fraze syndrome. Aberrant regeneration involves parasympathetic fibers traveling with which nerve? It's
Okay,
auriculotemporal nerve.
great. Okay, so let's just select it, and we. Anyone has any questions? We have added explanation about Frey syndrome. A lot of things we have added. So if you want, you can just give a reading from here. So let's move on to our next question.
Sorry, sir. Before we
Yeah, sure.
about this preferred, I preferred then and like this. I see it. I saw it in the arrows.
Yeah.
I think they ask questions about if you can have this little clarification after the session. No problem. That from ear to tongue, from ear to pharynx, like this, because it's very confusing, and I know it will need. Uh, in fairness, sir, I remember I see this one otalgia Vegas
Yes.
also,
Yes.
glossopharyngeal also,
Yes.
now this lingual. So just
Yeah.
simple like points
Okay.
about
So you are
uh,
just asking. So I just make a short video. What if I make a short video about it, and
would be
so
good.
I can explain a little bit
Yes,
about it?
yes.
Okay.
Appreciate it.
Okay. I will explain the referred autolgia a little bit. So let's read the next question.
May I?
Yeah, sure.
A 56-year-old man with a skull-base tumor compressing foramen ovale develops numbness of lower face, weakness in chewing, and loss of jaw jerk reflex. Which structure is most directly injured? I think
Okay.
it's
So read the options.
Mandibular division.
mandibular division.
Yeah. Great. 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 So okay. So everyone knows it. So let's just move on to next question. Who wants to read it?
May I?
Yeah, sure.
Patient complains that ordinary sounds seem uncomfortably loud and boomy, especially while chewing. Which muscle denervation best explain this? Nerve to
Okay.
stapedius, levator veli palatini, tensor tympani, tensor veli palatini, and salpingo pharyngeus.
Okay.
My
So what's your
answer
answer?
would be nerve to stapedius.
Yeah, the nerve to stapedius is has some problem. So the muscle stapedius has been denervated. Simple and nice, and I think you people are doing really great. You people are doing really great. So let's move on to next question. Who wants to read it?
A 45-year-old man
Yes.
presents with a sudden onset of right-sided facial weakness.
Okay.
He cannot close his right eye. His mouth droops on the same side, and food accumulates in the oral, vestibule. However, his hearing, lacrimation, and taste sensations are preserved. Where is the most likely site of the lesion?
Okay.
Mm,
So read the options.
Geniculate ganglion A, above the origin of stapedius. B, above the origin of the chorda tympani. C, at the stylomastoid foramen. And internal acoustic meatus.
Okay. So what's your answer?
Let me just think for 5 seconds.
Yeah, sure.
At the stylomastoid foramen.
Okay. So tell me your supporting points.
Well, the question says is he's hearing nerves to stapedius, lacrimation, um, uh, and taste sensation. Chorda tympani, they are preserved. So the
Yeah.
lesion should be down below.
Yeah, exactly. So the lesion is down below. So
Finally.
what? Great. So what do? You just draw a line. This is our geniculate ganglion GG, and before that, stylomastoid foramen. Here we have stapedius, nerve to stapedius, or hyperacusis. Here we have lacrimation. Here we have taste. Here we have facial expression. So this is okay. This is okay. This is okay. So the lesion is here.
I have a question with this diagram, if you will.
Yeah, sure.
If we have an injury in the geniculate ganglion, shouldn't the lacrimatory nerve also be involved?
Yes, that can be. Let me just draw it again and show you. So let's say here we have the genu. Okay. So here we have lacrimation. So if you have a lesion exactly at this point, so there can be two scenarios. Lacrimation can be intact if it's involved. Lacrimation can be spared if it's not involved. Okay. So there can be two scenarios in this case. So in your exam, you will always have either proximal to geniculate ganglion or distal to geniculate ganglion. So you get only one scenario. Because if the lesion is exactly at geniculate ganglion, the scenario, the presentation can differ from person to person. If the nerve is totally involved, then of course lacrimation will not be there. If that's not involved, only some other branches are involved. So this can happen. So in your exam, so you'll have either proximal or distal lesion. Okay. So it varies. Now, if they say, like, how will be the question? We have to imagine it a little bit. So if they say that lacrimation is intact, you always go for distal to geniculate ganglion. If you don't have that option or any option below, then you select geniculate ganglion. Did you get it?
Yes, of course.
Yes,
Thank you.
because from the options you have to choose the best option. They can give it that you have a lesion in geniculate ganglion, but lacrimation can be intact if the lesion is small and it has not involved your GP or greater petrosal nerve. Okay. Okay,
Yes,
guys,
thank
let's
you.
move on to great. So let's move on to our next question. Tell me.
A 30-year-old woman presents with facial asymmetry, loss of taste sensation in the anterior two-thirds of the tongue, and decreased salivation. However, her hearing and lacrimation are preserved. The lesion is most likely located A, above geniculate ganglion, B, above the origin of stapedius, C, above the origin of the chorda tympani, D, at the stylomastoid foramen, E at internal carotid canal.
Okay, so what's your answer?
I think I should go for above the origin of the chorda tympani, C.
Okay, so this is the right answer because see, because we can see very clearly that facial asymmetry. So it's below stylomastoid foramen or at stylomastoid foramen here. So facial asymmetry. So the lesion is here or above. Then loss of taste. So here we have chorda tympani. So it's above taste too. So it can be here. But in the middle of that we have hearing. So hearing is normal. So the lesion will be in between chorda tympani and hearing, above the origin of chorda tympani. Okay, guys, let's move on to our. These questions are very important, and that's why very important because they always give questions like that. So, who wants to read it?
May I?
Nine.
Yeah, sure.
Okay, I'll read.
Okay.
A 22-year-old woman complains of loss of taste on the anterior two-thirds of her tongue and decreased salivation. She has no facial weakness or hearing problems. Which branch of the facial nerve is most likely damaged? A. Greater
Okay.
petrosal nerve. B. Nerve to stapedius. C. Chorda tympani. D. Auricular branch. E. Temporal branch.
Okay. So, what's your answer?
So my answer would be on the chorda tympani branch because she has loss of taste and decreased salivation, but otherwise no motor weakness or hearing problems. So it would be on the chorda
Yes.
tympani.
Great. So, you people are very clear about your answers, and that's a very good thing. And that's a very good thing. Okay. So, should we move on to next question? Who wants to read it?
May I?
May
Yeah, sure. Anyone? Tell me your names, please.
Ujma.
Yeah, Ujma, read it.
A patient presents with right-sided facial weakness and complains that sounds seem abnormally loud in the right ear. Taste
Yeah.
and vision are intact. Which branch of the facial nerve is most likely affected? It will be
Okay.
stapedius.
Yeah, exactly. This was a very easy question. So, next question. Who wants to read it?
May I?
May
Priya, sure.
I? I'm sorry, I'll let Dr. Uzma speak, please.
No, you can read it. No problem.
Okay. A 28-year-old woman with Lyme disease presents with acute facial paralysis. She cannot wrinkle her forehead, close her eye, or smile on the affected side. Which of the following would best differentiate a peripheral facial nerve lesion from a central stroke lesion? A. Drooping of mouth. B. Inability to wrinkle forehead. C. Loss of corneal reflex. D. Hyperacusis. And E. Taste loss. My answer would be B. Inability to wrinkle forehead.
Great. So, inability to wrinkle forehead is the right answer. So, what are your supporting points?
Sorry, in case of UMNL lesion, there is an inability to wrinkle the upper side of the forehead, but in case of the uh, lower motor neuron lesion, the whole side is affected. Not the whole side, just the lower third is affected. Lower part is affected.
Okay. So, anyone has any question? Okay. So, let's assume no one has any question. So, okay, you will understand it. Um so, we have. Okay, read this question, please.
A patient presents with dysphagia and loss of taste sensation in the posterior third of the tongue. Which additional deficit would you expect in glossopharyngeal nerve injury?
Okay. So read the options.
Loss of corneal reflex, hyperacusis, loss of salivation from parotid gland, loss of lacrimation, loss of sensation from anterior 2/3 of the tongue.
Okay. So what will be your answer?
C, loss of salivation from parotid gland.
Okay. So loss of salivation from parotid gland. So can you tell me what else we could give here? That what are the other deficits? Like what are the functions of glossopharyngeal nerve? What are the other deficits we can have here?
Absent gag.
Swallowing. Yeah. So it's motor to stylopharyngeus. So we can have dysphagia, problem with swallowing, right?
Yes,
Yeah.
yes.
Problem with swallowing. Then we can lose afferent limb of gag reflex,
Gag reflex.
right? Afferent limb of gag reflex. So this is very important. Gag reflex. They ask questions from it. Okay, so let's move on to next question. So we have solved these questions before, and after that, all the questions are from glossopharyngeal and vagus. So let's wrap up this session for today, and we will have our next session on head neck. And solve the question yourself and read the question explanations. If you have any questions, you can ask me anytime. But I will answer whenever I'm free. Okay. I can be late, but I will always answer.
Okay.
Okay, guys. Thanks
Thank
a
you for
lot for
the
being with me.
class.
Thank you.
Okay. Have a good night.